So today we will be talking about regulations. We've noticed that when students graduate and then they come into the lab, it's not something that we're really discussing during school. So everyone's very confused about regulations. So I wanted the discussion board up so we could kind of talk about what we know, which I was surprised how much some people knew, but I wasn't expecting anyone to really know that much about regulations. So what we will be talking about are lab regulations versus personnel regulations, accreditation versus certification, regulatory bodies and standards, regulations, and laws. And I was going to talk about quality principles in this lecture, but it ended up being pretty long, so I left quality off. So maybe that'll be another lecture at another time. So I left these abbreviations. All these regulatory organizations, usually they have pretty long names. So usually we say the abbreviations. We don't say Food and Drugs Administration. So here's the abbreviations that we'll be using during this lecture. I also have some definitions here that you might want to refer to or come back to. So first we'll start with lab regulations. So who regulates the lab? So, and to be specific, who regulates the clinical lab? And a clinical lab is defined as any lab performing patient testing other than research labs. Research labs do not have to obey the same rules that clinical labs do. They are under the oversight of CLIA. CLIA is the Clinical Laboratory Improvement Amendment of 1988. It was written into federal law in the CFR Title 42, Part 493, Laboratory Requirements. And this is administered by the Centers of Medical and Medicaid Services. So this is why regulatory is so confusing to everyone, because there's laws, there's so many different organizations. Some people have power, some people don't have power. So it's very complicated. So that's why I wanted to kind of address this and break it down for you guys. So what is CLIA? It's basically the ultimate rule book for clinical labs. They have requirements for all of these areas, and we're going to go through each one to talk about the specific requirements. So first, competency requirements. So this is really important. One thing I didn't address here is what is competency? So basically it is confidence that you know what you're doing before you're performing a test on a real patient. So how frequently do you need to do this? Employees need to show that they are competent for each test that they perform before actually performing that test on a patient by themselves. So you're not going to just get thrown into a lab and they're going to say, okay, go ahead and do the cross-match for this patient. You're going to have a trainer and they're going to watch you do it, make sure you're following SOP and that you know how to do it, and then they're going to sign you off. So each lab is kind of different how they do sign-offs. Some people will use paper forms. Some labs will have an electronic documentation system where they sign you off. But the key point is there is a trainer that has witnessed you do it and believes you are competent enough to work alone. Then during the first year, most people have this set up to be 6 months after you get signed off. You have to be observed again to make sure you're doing it correctly, because some things do stray. So you might think you're doing something right, and then it turns out you started doing something different. I have a question. I will address it in 1 second. And it's actually a very good question. So anyway, at 6 months or so, you'll get a competency check, and then you are required to have a competency check annually. So every year. And why is this important? Because people sometimes just start doing whatever they want, or they start making shortcuts. And so it's important to make sure that everyone is doing things the same way and the correct way. And what does it mean to have your competency checked? So CLIA breaks down into 6 different categories. This is a big thing because some people were only doing 1 of these things or 2 of these things or whatever is easiest, and you will get write-ups if you are not doing every single one of these. So direct observation of the test, monitoring the records and reporting of test results. So you want to make sure they know how to perform the test and they know how to record the results correctly. Review of intermediate test results or worksheets, quality control records, proficiency testing results, and preventative maintenance records. So we want to know that when they're doing the startup of an instrument, they know how to document that correctly. If they're doing maintenance on an instrument, they're documenting that correctly. Direct observations of performance of instrument maintenance and function checks. So it depends what kind of instrument you're talking about. Sometimes it's very simple, it could be a cell washer, or it could be a very complex instrument that requires very complicated startup. Assessment of test performance through testing previously analyzed specimens, internal blind testing samples, or external proficiency testing samples. So we'll talk about proficiency testing a little bit down, but if you don't know what proficiency testing is, basically you will pay someone, which there are multiple organizations that provide proficiency testing samples. They will, for each test, they will make up a lot of sample and then send it to different labs, and you will test it and then report your results back to them. And then they will look, they'll compile all the results from all the different labs and then compare all the results and make sure that all the labs are getting the same results, basically. And you basically get a report card for each test you do, and it'll say you performed this closely to other labs, or your result was too far off from other labs, and you'll get a pass or fail grade. So it's good to assess competency with, because it's an external source doing it. It's not, and I don't know, I mean, we don't have this problem here, but you hear all kinds of nightmares. If you're on like medtech Facebook groups, people tell stories of like very horrible lab conditions where like the supervisor is best friends with one of the techs and they let them do whatever they want. So if you're in that situation, it's like, are they really making sure that that person is competent? Well, if they're testing an external proficiency sample, then it's a impartial person, external, so they would catch if there was something wrong. And then the 6th thing you have to do is assessment of problem-solving skills. And this is a very important one to me because techs need to know what can go wrong with a test, how to know if something went wrong with the test, and how to address problems when they happen. So you can do that a number of different ways. Some organizations will have a checklist or a quiz that will say, you know, if you see this result, what does that indicate? Or what would you do if this happened? So CLIA is very vague in how you have to perform these things, but you need to have your own SOP at your facility for how to address them. And in Florida, you must be assessed by a licensed supervisor. So to be a supervisor in Florida, you have to have 5 years of experience in that specialty area. So that is an extra check because it's not a brand new tech that's watching you. It's actually someone that has experience and knows what they're looking at. And the question was, during internships, is it similar process or do we just generally shadow the trainer? And that's going to depend on your rotation and where you're at. Some places you will, just depending on the type of, testing, you might just shadow someone. You might just like chase them around while they're working, or they might actually let you do stuff but watch you the whole time, or you might be given like fake patient samples or old patient samples to test so that you're not actually testing, you're not going to report out any results. And that is important because under Florida law, with your trainee license, you cannot report any results. And we will talk about that later on too. So moving on, CLIA validation requirements. So there is validation and there is verification. And this is when you get a new instrument or you bring on a new test, and you can imagine this is very varied. If you get a very simple little instrument, it's going to be a lot simpler than if you get a very complex like chemistry analyzer. You're going to do a lot of validation studies to make sure that everything works correctly. Whereas if you get a tube centrifuge, you're just going to make sure that you are still going to have to validate that it centrifuges the samples correctly, but it's not going to be as complicated as if you're validating a whole new analyzer that does multiple assays. Okay, back to the question. So signing off on competency. So as a student, competency is making sure you're competent in, doing the test. So that would be that you'll have a checklist of all the things you need to be competent in. So that is, you know how to perform that test, but you won't necessarily be doing it on patient samples.
Gotcha. Thank you.
Yeah. So what is the difference between validation and verification? If an assay is FDA approved IVD, which is in vitro diagnostics, basically that business or company that made that assay has gone through such rigorous testing of that assay that the FDA has approved it, and you don't have to redo all that testing that was already done. So you just need to verify that it works for your population. If it has not gone through FDA approval, you pretty much have to do everything yourself to prove that it is safe to test patients with that assay. So in verification, you need to perform accuracy, precision, reportable range, and reference range testing. Whereas if you're performing a full validation, you need to do more testing than that. So for a validation, if it is not an IVD test, so an RUO assay, or you develop your own in-house test, or if you modify an IVD test in any way. So IVD tests, they have protocols that come with them. And if you change anything about that protocol, basically it's not an IVD test anymore, because that's not how the business or the company tested it. You've made it a RUO test, and RUO stands for research use only. And LDT stands for lab developed test. So if you're performing a validation, you have to do accuracy, precision, reportable range, reference range, which are all the same things you have to do for verification, but you also have to do analytical sensitivity and analytical specificity. And we'll go into those just a little bit. Okay. So what is accuracy and precision? And I hope that you had this maybe in your chemistry or in your lab management book, classes. But precision is basically saying how close are the values of one sample. It's not saying that it's correct, it's saying that it's close together. So if you run one sample 10 times, all the results are very close together. And accuracy is saying how correct is the value against the reference method. So the bullseye picture is very helpful to think about this. And these are things I would know for the board exam. Because a example question you might see on the board is they might give you a list of results and say, a lab manager was validating a assay for sodium. The results were 100, 123, 157, whatever. And it'll say, are these results accurate or are they precise? So if you look at the bullseye, can you see my pointer?
Yes.
Okay. The lower right-hand side, this is very precise. All those results are very close together, but if the bullseye is the correct result, it is not very accurate. Then above it, all of these results are very close to the bullseye, and they're all very tight. So this is a very precise and accurate test. And then the one to the left, this one is pretty accurate and pretty precise. And then the one under that, it's not very accurate and kind of precise. So the top right is what you want in your lab test. So reportable range, or in chemistry, we say AMR, analytical measurement range, or linearity. This is basically, you're going to run a bunch of known samples, which are usually calibrations. And when you plot those results, you want them to be a very tight line. But at some point, it's going to drop off. It's going to be too dilute, or it's going to be too concentrated. So by running validation or calibration, you are establishing your reportable range. So it's basically, what range is your result accurate? Can you report it? So you want to test very low samples and very high samples to verify that your range is good. The reference range, usually the company will give you a reference range that they used for all of their studies. It is not required that you repeat this. Usually you will just verify the manufacturer's reference range by running 20 samples. Like in this example, there's a range for females and a range for males. So in that case, you would want to run 20 males and 20 females. If you want to establish your own range, because you live in a very weird place that might have weird results, you would want to run 100 samples to establish your own reference range. And then there's analytical sensitivity and analytical specificity. So it's kind of similar to your linearity. You basically want to know the lowest concentration that can be reliably detected, and then the highest concentration that can be reliably detected. And then some of the other testing we do, CLIA doesn't require this, but it's good to do this, depending on what kind of assay you're doing. You can do carryover studies, which you want to make sure that if you're testing an analyte and you have a really high concentration, that the next sample is not going to be contaminated by that high sample. So if you're using an instrument that has a probe, you want to make sure that the probe doesn't carry over to the next sample. And then there's stability studies too. So you want to confirm that if you say your sample is acceptable for 5 days after collection, you want to verify that by testing on day 1 through day 5, that the sample result is going to remain the same throughout that 5-day period. Okay, and how do we report this? Or how do we do a validation? When we write a validation plan, we usually break it into IQ, OQ, and PQ. So there's installation qualification, and that is the easiest part. It's just installing the equipment. Usually when you get a new equipment or a new instrument, they will have like space requirements, temperature and humidity requirements. So you want to get it set up and then make sure that you're in all those ranges, that the temperature is okay, the humidity is okay, you have enough space. Some instruments will have like vents, so you can't put the vent all the way against the wall. So you want to make sure that the installation of the instrument is okay. And then there's operational qualification. So then you just want to make sure that the instrument is operating as expected. So that is totally dependent on the instrument. It's going to change very drastically between a chemistry or a hematology or whatever instrument it is. But you can go through and do like maintenance or startup and shut down, making sure it is operating as it is supposed to. And that also includes errors. So like if you want it to alarm for certain things, you want to actually challenge the instrument and do something that you want it to alarm for and make sure that it does alarm. And then there's PQ, performance qualification. And this is when you do all those validation tests. You can do method comparisons. So for example, if a lab replaces their chemistry instruments every 10 years, you can't just get rid of your old instruments and replace them with the new ones. You want to do a method comparison. So you're going to have to jam everything into one lab and then test a sample on your old instrument and then test it on the new instrument and make sure those methods compare. And then you want to do reproducibility. And when you're doing that, you want to do it, look at inter-run and inter-operator. Make sure that all your techs are getting the same results. And if you run a sample in the morning and then 2 hours later, you're getting reproducible results, and then precision as well. Okay, so now on to PT requirements. So this is proficiency testing. So it must be performed on each test that the lab performs. And the PT must be from an agency that is approved by CLIA. And there is a list of all the approved agencies on the CMS page. CAP is the most popular one. So you'll hear that a lot, like, oh, we got a CAP survey for this. The frequency depends on the assay, but usually you get 3 shipments a year. And it also depends how many you'll get. You might get 1 sample during a shipment, or you might get 5 samples during a shipment. These samples must be processed how a patient would be processed in a normal workflow. They don't want you to treat this special. They want you to treat it just like you would treat a patient. And you cannot discuss your results, and you cannot send these out to a reference lab. They are very, very serious about this. So be very careful. Like, if you work at one hospital and your best friend works at another hospital, you cannot be like, oh, I got the CAP survey for this. Is this the result that you got too? Like, you can get your lab in trouble, and you can get yourself in trouble. And the samples must be rotated through staff that perform the assay. You can't, every time a sample comes in, give it to your supervisor and say, this is hard, why don't you do this? They will look at this and make sure that everyone is getting a chance to do these. So yeah, what we do is we make CAP gives you a shipping schedule at the beginning of the year that'll say the name of the survey and then when it's expected to ship. So we make a list and basically make sure that we rotate staff with every shipment. And what happens if you fail PT? So what is failing? Basically, if you get under 80% in each lab area. So that would be like all your hematology surveys, you have to get 80%. Or if you have 2 out of 3 shipments for a year or 2 consecutive failures, it requires official documentation. At that point, CMS can choose to revoke the lab's ability to continue testing and to receive reimbursement. So it's not good. It looks real bad if you fail 2 in a row, because it is really basically, can we trust your results? Like, we don't know if we want you to do patient testing anymore. So usually if it gets to that point, you have to do 6 months of successful PT before you can be reinstated. And here's an example. So this is, CAP is really nice. They'll give you a little scorecard for each specialty. So this one's in hematology, and they'll list all the tests that you do on the left, and then they'll list each event. So in 2021, this is our first kit, our second kit, and our third kit. So we got 100 on the first shipment, 100 on the second shipment, but then we got an 80% on the third shipment. So that is still satisfactory because you just need to make an 80. So our overall, we were successful in hematology. And what happens if there is not a kit available for an assay? So this can happen if you're in like a reference lab and you're doing very niche tests, or you're doing a lab developed test, or you're just doing a very, very, very special test. CAP may not have a survey for that. So you do have some other options. You can split a blinded sample within the lab. So you can get a sample big enough, split it in half, and then have different techs do it, and then compare those results and make sure that they're comparable. That is okay for like time-sensitive things that you can't send out, but it still isn't super great because you're relying on someone in the lab to judge those results. So you really want someone external to the lab to be analyzing these. So you can split those samples and then send to a different lab. So that's what we do with a lot of molecular tests. We'll have someone will be responsible for kind of managing the survey, and they will extract a bunch of DNA and then send it to the 20 labs that do that test. And then everyone will return their results to that first lab, and then they'll go through and make sure everyone got the correct answers or the same answers. And then they'll send out a report saying, your lab did great. And that's great because it's an external source. Yeah. Okay, moving on to QC requirements. So CLIA QC requirements are based on test complexity. So basically, the more complex a test, the more rules, because you want to make sure that it's being controlled. So in general, there's waived, moderate complexity, and high complexity. So waived tests are very simple tests that someone off the street could do. Like if you got someone that at-home COVID test or a pregnancy test could be an example of a waived test. It's something very, very simple that has directions and that are very easy to follow, and most people could just read that and do it. Then there's moderate complexity. So those are more complicated, but not crazy complicated. And then there's high complexity, which in manual testing labs, like in blood bank reference labs or flow cytometry labs, pretty much everything we do in my lab is high complexity. A lot of molecular labs are high complexity. There's lots of room for error in these tests, so there's a lot of QC requirements. And we won't go into it because there's too many to talk about. And then kind of lining up with the test complexity, there's also personnel requirements. So the CFR includes responsibilities and qualification requirements for a lab director, a technical and clinical consultant, a supervisor, and testing personnel. And it all depends on the complexity of testing. So the requirements for testing personnel for wave test, there are none. Anyone can do this. So like if you get a rapid strep test when you go to your doctor's office, it doesn't have to be a med tech performing that. Anyone, a nurse, a doctor, anyone can do that test. Moderate complexity, the minimum requirement, this is CLIA requirements. You have to have a high school diploma, and then you have to have documented training for the testing performed. So there is on the CMS website or the CLIA website, you can look up to see exactly what complexity a test is. There's a list of basically any laboratory test performed. And it's broken down by manufacturer. So you can go in and say Sysmex CBC, and it will say moderate complexity. Every single test. If you're like, I don't know what complexity this is, you can look it up on the website and it will tell you. So it is important when you're bringing on an assay to look it up and see what its complexity is, and if you have the staff that have this level of skill that can do this test. So for high complexity testing, the minimum requirement is an associate degree that has 24 hours of science and completion of an accredited or approved clinical training program, or 3 months laboratory training in the specialty in which the individual performs high complexity testing. So note that CLIA high complexity minimum is associate's degree and either a medtech program or 3 months lab training. We'll come back to that. So then there are CLIA laboratory certificates. So every lab performing patient testing has to have a CLIA certificate, and it depends on the level of testing that you're doing. So even if you're just doing waves test, so a lot of doctors' offices that are just doing little rapid tests, they'll have a certificate of waiver, which means they are allowed to do those tests, just wave tests, nothing complicated, just waved. There's a certificate of provider performed microscopy, and that is usually physicians or dentists performing, just looking at a microscope. So might be doing a wet prep or some kind of dental swab and looking at a microscope. That's all they're doing, only looking at a microscope. That's it. And then there's certificate of compliance and certificate of accreditation. So the certificate of accreditation is whenever you have accreditation through an approved organization, and compliance is when you are not going through an accreditation organization, which we're going to go into very soon. You're just going straight through CLIA, and then CLIA will come and inspect you. And then there is a fifth certificate, which is the certificate of registration. This is just a temporary certificate that's given to you when you open up a new lab. You have that certificate for 2 years, and basically you have 2 years to be inspected to prove that you are up to code, and then you will either get your certificate of compliance or certificate of accreditation. Any questions? Okay. This is a lot, I know, but I wanted to throw it all out there because I was never taught this. I kind of just figured this stuff out throughout the years. So I thought it'd be nice to have everything in one place and just give you a crash course. Okay, so how are labs assessed to make sure that they are following the regulations that they're supposed to be following? So there is CLIA Enforcement. So CMS, FDA, and CDC are responsible for enforcing CLIA regulations. CMS grants deemed authority to accreditation organizations to conduct inspections for compliance with the CLIA regulations in conjunction with the inspection process to verify accreditation requirements. So that's a mouthful. So who are these organizations? Selected accreditation agencies have the authority to verify compliance with CLIA regulations. When the laboratory requests participation in the accreditation organization, they will come and inspect you, and they will make sure that you are following the CLIA regulations, and then they will have their own regulations. So there is, like, basically anything you need to find, you can find on the CMS website. It has a chart for who can accredit you in what areas. So I cut this off so it would fit on the screen. But basically there's AABB, the main ones are AABB and CAP. and then there's Joint Commission. So Joint Commission is for hospitals. So most hospitals are part of the Joint Commission. So they will come and inspect the entire hospital. But most hospital labs, because Joint Commission, they're not really honing in on the laboratory. They're looking at everything. Like, are the beds clean? Are the walls clean? Are the floors slippery? So usually if you're in a hospital, you will be inspected by Joint Commission and probably CAP, because CAP are specific to the lab. They know what they're doing. So you'll see that, because if you're in the lab, you might be like, we just got inspected last week. Why are we getting inspected again? It's probably a different organization inspecting you. Okay, so these organizations will have standards or checklists that are normally more detailed than the CFR. So all the CLIA requirements are in the CFR, which is the Code of Federal Regulation. Remember, these are not regulatory bodies, they're accreditation services. So they cannot shut you down. If things are really bad, they can report you to CMS and CMS can shut you down. So what do these inspections look like? Most accrediting organizations will schedule inspections to occur once every 2 years. Some are surprise inspections and some will be planned. You should be inspection ready at all times. And how do you get inspection ready? Basically, you need to know your standards and your checklist. You need to know how you will answer when an inspector asks you how you comply with those standards. And you need to know where you keep all your documentation, because they will show up and they will say, give me evidence that all your personnel have the right training. And then you'll have to find your training documents. You have to find your competency documents. So you need to know where everything is. And you, meaning if you're a supervisor, as a baby tech, usually they will walk through the lab and they might ask you a question, but usually normal techs aren't a huge part of inspections. You just want to make sure you're doing everything correctly when they walk through the lab. Like, you have your PPE on, you're not eating a cheeseburger in the middle of the lab, stuff like that. And these organizations, their checklists or standards are really nice because the CFR is pretty vague. So the standards make sure that they are covering the CFR in addition, above and beyond that. So this is an example of an AABB standard. These are nice because they'll have the standard and then they'll have questions to make sure that you understand the standard and that you're actually following the standard. So, like calibration of equipment. Calibration and/or adjustments shall be performed using equipment and materials that have adequate accuracy and precision. Calibrations and/or adjustments shall be performed before initial use, after activities that may affect calibration, and at prescribed intervals. So what the inspector might come to you and say, what is the schedule for monitoring equipment? How do you know if a particular piece of equipment has been calibrated and when it's due for calibration? And what is the process for determining the calibration interval? So again, your supervisor or manager needs to know this information, but it never hurts to know things. So don't be afraid to jump into the standards when you get into a lab. It'll help you understand things. Because you might read SOPs and you're like, this is so stupid, why do we have to do this? And it's probably because it's in a standard. Here's another example of a CAP checklist. So they will have a standard number, and then they'll kind of describe what they're expecting. So QC corrective action. There is a record of corrective action taken when control results exceed defined acceptability limits. So some of the standards, they will require documentation. And some of the standards, you don't have to have it written. You just have to know that you are doing that. But usually what we do to prepare for inspections is we go through the checklist and we write down where that standard is addressed. So like for the calibration one, we write down, this is covered in our QC maintenance procedure, so that we know we're prepared. When they ask you, how do you know you do this? We say, because we have a SOP that addresses this. And then FDA inspections are kind of separate from the CLIA inspections. FDA is charged with overseeing the collection and distribution of human blood products. So they kind of think of blood as a drug, which is being used as a drug, if you think about it. Transfusion services and blood banks are inspected by FDA inspectors, utilizing unannounced inspections. So they don't warn you, they just show up, and then you got to get ready. This is why you need to be inspection ready at all times. Why you want to keep your lab clean, your documentation up to date, because at any point, an inspector can walk through the door and say, why does this maintenance form not have anything on it? And we're on day 12 of the month. So FDA inspects all blood facilities at least every 2 years. And if you're a known problem facility, you'll be inspected more often, which should reassure you in case you ever need blood. The FDA does take blood very seriously. The FDA is not an accreditation agency. They do not verify compliance with CLIA. So this is why if you work in a transfusion service or a blood center, you will usually be accredited by CAP or AABB. Then if you're in a hospital, you're also accredited by Joint Commission. And then you'll also have an FDA inspection. So if you're in a hospital blood bank, you can get a CAP inspection, a FDA inspection, and a Joint Commission inspection. So you can just be hit like back to back to back, which is super fun. So what happens after the inspection? After they have gone through and checked that you're performing everything correctly or asking for documentation, you'll have a conclusion or a summation at the end of the inspection. And let me tell you, if you prepare for inspections and you know where to find things, these inspections will go so much smoother and be so much faster. Like sometimes they'll come and they'll be expecting to be there a week. And if you just, every time they ask a question, you're like, here's the SOP, here's the documentation. Like sometimes you can finish that up in like 2 days and they'll be like, your facility is amazing. Your documentation is amazing. And then they'll leave you alone. So it's wonderful when that happens. But if they do find problems, there'll be an inspection report. So if it's a CMS inspection, there's standard citations that are not very severe, but you need to fix a problem, and then you need to send a response on how you fix the problem. Then there's conditional citation, which is a serious problem, and that requires them to come back to visit you to make sure that you have corrected the problem. And then accreditation inspections like CAP or AAB, they will issue a deviation, which they require a response. It's basically like, you are not compliant with our standards. You must prove that you are fixing this. And then there's recommendations, which if they see something that you could be doing better, but you're not actually breaking a standard, they will recommend that those things. You don't have to do those. And depending on the inspector, sometimes you're like, oh, that's overkill, I'm not going to do that. But sometimes they are really good recommendations that can help your workflow and help clean things up. So sometimes you do want to take those recommendations. And then when the FDA inspects you, their report form, if you have any problems, is called a 483. So this form documents any errors or deviations that they detect during their inspection. These are available publicly in a searchable database. So like if you have a hospital stay and you want to look up if that hospital has any citations, you can actually search the FDA website to see what that hospital has been dinged for. So it's kind of nice. And you do have to respond to those observations. Okay, so what's the difference between federal and state regulations? So CLIA is federal, but they are federal laws. And we will talk about Florida specifically, because that's where we are. In Florida, we have the Agency for Healthcare Administration. It is the state agency that oversees clinical laboratories, as well as a lot of other things. Federal regulations may be different than state regulations, but you have to follow both. And it's kind of like the accreditation organizations. Usually their standards are higher than the CLIA standards. Usually the state requirements are higher than the federal requirements. So if you obtain a state license in Florida, you need to ensure that you are following all the federal rules in addition to all the Florida rules. And Florida has statutes that you have to follow. And here's just a little comparison between CLIA rules and Florida rules. I like this chart because it shows where you can find the rules, who's responsible for enforcing this, contact information, who does this pertain to, what accrediting organizations you can use, breakdown of categories, so using the same categories, and then specialties, subspecialties. So in Florida, federal and state regulations are very similar, except when it comes to personnel, which this is the part that I really wanted to focus on for you all, so you knew about this, because this is very important. There's licensure and there's certification. So that is two forms of occupational regulation as far as personnel. So a lot of times these get very confused or they're misused, the terms. Certification is less restrictive. It can be given by a government or a private entity, and it doesn't deal with the quality of work performed or the competence. It is basically just giving you a title that you can use. So in our case, we have ASCP, Board of Certification. They have a list of requirements. So you will basically have to meet those requirements in order to pass or take the exam. Then you have to take the exam, and then you can use that title. It gives you a title. Healthcare personnel can be certified without being licensed. So if you work in a state that does not require a license, you will never be licensed. You will just be certified. So licensure is something that we hear a lot of. It refers to the right bestowed by a governmental agency or entity to engage in a legally defined occupational scope of practice. So with specified exceptions, this form of occupational regulation prohibits non-licensed individuals from performing certain services. And its intent is to assure the public that practitioners have met the qualifications and minimum competencies required for practice. Licensure can address the maintenance of a licensee's skill through continuing education and competency requirements. And it can also serve as a universal benchmark for entry-level personnel. State governments license hundreds of professions. One estimate indicates that more than 800 occupations are licensed by one or more states. Among healthcare occupations, there's physicians, nurses, midwives, everyone that works in healthcare, basically. And then there's also non-health related. So sometimes painters, contractors, school bus drivers, barbers, bartenders, tattoo shops, or tattooers can be licensed. And it is clear that laboratory operations, including testing, have a major role in assessing and managing patient health. So if you haven't heard it, like between 70 and 80 diagnoses are based on lab results. But most states do not require a license. As of right now, only 11 states and Puerto Rico require lab techs to have a license. And usually certification is utilized in America. Every state uses certification to verify that you meet the initial competency. So just to make this clear, a state may require a license to work in that state. ASCP is a certifying body. So when you take your ASCP MLS exam and pass, you will be a certified MLS. You still need a state license to work in Florida or the other 10 states. So just because you pass your exam, you're not there yet. You still got to get your license. Certification does not equal licensure. And here's an example of how to use all your credentials when you get them. So you'll have your name, you'll have your highest degree, you'll have the category, and then the certifying agency. So I am a certified histocompatibility technologist, and ASHI is the certifying agency. I also have my MLS and my molecular biology and my SBB degrees through ASCP, or not degrees, certifications. So if you have specialties other than your main generalist certification, you write those after. And then if you have a title that requires continuing maintenance, which MLS does, they require that you do continuing education and turn that in every 3 years. You must write CM after your name, because your certification is, it requires that continuing maintenance. If you forget to turn in your continuing education after 3 years, you are no longer certified. So remember that. And then just to be more specific, only use your highest degree. You don't need to put every little degree you've ever had. So just pick your highest one. If you have 2 equal degrees, but they're different, you can list both. So if you have an MS and an MBA, they're different, and those may be different to different people that you talk to. So you can list both of those. And then if you have multiple certifications in the same discipline, just remove the lower certification. So for example, for people that don't go through a medtech program, they can go through, for example, we have a blood bank medical technologist program here. So you can get your BB only, so you can only do blood banking. But then later you can take the specialist in blood banking exam. So you don't need to write BB and SBB. You only want to use the highest one. So you would turn that into SBB, ASCP. Any questions?
I was trying to unmute. I have kind of like an unrelated question.
Okay.
So how does that work? I know we're like set to take the generalist exam, like just the general MLS exam through ASCP. How do you then go about specializing? Like, is that after 1 year, 2 years of experience? How does that work? Or like extra classes?
It depends on which one you want to do. So there's additional flow cytometry exams. There's the additional molecular biology exam. So if the ASCP website is really nice, you can look at the eligibility routes for each exam that you want to take. So for example, molecular biology, because a lot of people that work in research and then they decide to go to a clinical lab, they just want to be certified in molecular biology. So if you are a generalist, you can sit for your molecular biology exam right away after you get your MLS certification, especially because our program is so heavy in molecular. If you're interested in doing that, I would go ahead and do it. Why not? If you do not have your MLS, then you would have to wait a year. You would have to work in a clinical lab for a year, and then you could sit. So most of the exams, they'll have either an education route or an experience route. But it depends on every specialty. They have different routes. And usually if you have a bachelor's degree, you'll need a certain level of experience. But if you have a master's or a doctorate degree, they allow less experience because they're assuming that you know more.
That makes sense. And then does that like equate to pay increases, or is it just like lab specific? Like you need that molecular biology certification to work in certain labs, or like what's the benefit of taking it other than saying, hey, I have this certificate? It
depends very much on where you're at. Some labs will give you a pay increase because they're assuming that you know your stuff. Or, for example, if you moved out of Florida, you wouldn't necessarily need you could use if you just had MB, you could work in a clinical lab outside of Florida. So there's different benefits to it.
Gotcha.
When you get into higher positions, like when you get into the like reference labs or high complexity labs, like if you are in an AABB accredited reference lab, to be a supervisor, you must have your SBB. So you come into situations like that. So basically, if you want to have any kind of higher level position, you might have to have additional certification.
Gotcha. Thank you.
And then a side note, some states require the actual lab to be licensed. So Florida used to do this, but they removed that requirement in 2018. But some labs will, like in Georgia, they do not require the techs to have a license. They make the lab have a license and then basically make the lab responsible for making sure that all the techs have the right education and training. Oops. So to give you guys an example, in Florida, the Florida requirement to be a technologist is all applicants for a technologist license must satisfy the requirements for high complexity testing under CLIA. So it doesn't matter if you're working in a lab that only does moderate complexity. To get your Florida license, you must meet the requirements to be working in a high complexity lab. Florida also requires that you have a certification exam. Most national exams require a bachelor's degree. AAB is the only medtech exam that allows AS degrees. So you can see medtechs in Florida that only have AS degrees. Continuing education is required to renew your license every 2 years. You have to take HIV again, medical errors, Florida laws and rules, and then you have to take 1 credit in each area that you're licensed, and then a total of a minimum of 24 credit hours. So if you're a generalist and you have micro, hematology, chemistry, everything, you have to have at least 1 credit in each of those, and then basically fill up the rest with whatever. So if you love molecular, as long as you hit 1 credit in each, you can do the rest of your credits in molecular. So what are the benefits of licensure for lab personnel? And I want to say I was really pleased whenever I saw your comments on the discussion board, because I see in the MedTech Facebook groups that people are very cynical. They're like, they only care about your money, because you do have to pay, it's like $95 to renew your license. The state only cares about money. They just want to take your money. It doesn't help you at all. And this is why I think it helps you. One thing, it helps guard patient safety, because you know that if you are performing a lab test, you have the required education and training to do that test. And that all the medical technologists in Florida are quality. You have continuing education. So continuing education is really important to me, because our field changes so rapidly. Like, you think about COVID, and COVID tests came out so fast. And just all the new technology that's coming out, things evolve so quickly in this field, to make things better for patients, to make tests faster. And it is our responsibility to make sure that we are educating ourselves so that we understand what's happening, and so that we can advocate for our lab. Like, I recommend you subscribe to like email lists from different organizations like MLO and ASCP and AABB. I'll upload a list of organizations, because most specialties have a specific organization. Like, there's lots of molecular organizations. AABB is the blood bank organization. Then there's chemistry, hematology. It does get expensive to be a member of all these organizations, but they provide you continuing education, and you're getting a lot of information. So, like, if you're passionate about one field, I suggest being a member of that organization, so that you can learn about all the new things coming out. And it's exciting, because then if you see like this new exciting assay came out, and it's so much easier and faster and better than the one that you do, and you can take that to your lab manager and say, look at this, it's so great. You know, next fiscal year, can we put it in our budget to do this? So you can help improve quality in your lab. But that was a digression. So it also makes the HR process really easy whenever you have your license, because it's really nice. You can look up Florida licenses. It's free. There's a website, and you can go there and type someone's name and confirm that they have a Florida license. So you don't have to, every single time you move to a different job, you don't have to pay ASCP to send your verification, because they do make you pay to verify that you're certified. You don't have to get your transcripts sent, because basically in Florida, we know if you have a license, you meet the minimum requirements for Florida. And then it also is job protection and wage protection, basically, because there's so many requirements. There's a high demand for med techs, especially right now. There's such a shortage. So usually high demand drives wages up. So it's good for us, I think. So after listening to this, I'm sorry I went over. I knew this was going to be a really long one. Go back to the discussion board and just reply to your original post and add your updated thoughts on what you learned or if any of your thoughts changed on licensing and regulation. And do you have any other questions for me?
No, thank you.
Okay. I do have another lecture for you next Friday. So I will see everyone next Friday. Have a wonderful weekend.